is thyroid disease. Is a thyroid disease in pregnancy. So it's very important to understand thyroid gland regulation. We all learn this in biology 101, but just remember the hypothalamus releases TRH, and the thyroid releasing hormone then hits the anterior pituitary gland to release thyroid stimulating hormone, which goes down to the thyroid gland and says, hey, make some thyroid thyroid T3 or T4. Once it's made, it's released from the thyroid gland and entered into the bloodstream. And then as the blood passes the hypothalamus into TSH, they will shut down or decrease as the amount of thyroxine goes up. You can not do that, okay? It'll or decrease the amount of TRH and TSH that's being released. So it's very tightly regulated. Next slide. So it's important to understand that most of the hormone that's released is T4, and T4 is 85 to 90% of the hormone released from the thyroid gland. Now, most of that is bound to thyroid binding globulin, and only a small percentage is free. The same thing goes with the release of T3 from the thyroid gland. Most of it is bound to thyroid binding globulin, and a very little of it is free. T3 is actually the active form of the hormone, and T4 can be converted to T3 in the periphery. Next slide. So what are the changes in pregnancy? So TSH essentially stays the same throughout pregnancy with one exception. And that is in the first trimester. Your TSH, ideally, we would like to know what the TSH is in our own pregnant population. And occasionally you'll see that from big labs like LabCorp, but smaller like hospital labs, there is not a trimester normalized TSH. And if there's not, then what you should do is reduce the lower limits of normal by 0.4 and increase the upper limits of normal by 0.5. Now, total T4 and total T3 increases dramatically in pregnancy. By 16 weeks, it's 1.5 times the baseline. But the free amount of hormone, T4 and free T3, stays the same. Now, the whole reason that T4 and T3 total goes up is because, remember, I told you it is secreted and bound to thyroid binding globulin to be transported throughout the system. And thyroid binding globulin is affected by estrogen, and it increases the amount of TBG and therefore your total T4 and your total T3 are increased. So when I'm looking at pregnancy hormones or the thyroid gland, I only order a TSH and a free T4 because the total T4 and the total T3 looks wacky. Next slide. So let's talk about hyperthyroidism in pregnancy. Most of the things that with hyperthyroidism we see in pregnancy can be there may be a misconception that these are normal pregnancy findings. Nervousness, tachycardia, palpitations, heat intolerance. Most pregnant women are hotter than non-pregnant women. Weight loss is not that common in pregnancy. Insomnia is very common. Patients will tell you, I haven't slept in weeks because I get up every hour to use the bathroom. Hypertension is also common in pregnancy, but there's two things that are unique to hyperthyroidism, and that's your ophthalmopathy, and you can also have a lid lag, and the lid can look like it's retracted, and dermopathy, which is localized or pre-tibial myxedema. In normal pregnancy, the thyroid is more commonly palpable than in the non-pregnant state. 30% of women who are pregnant have a palpable thyroid. And in normal patients, it's hard to feel the thyroid unless there's a goiter there. Next slide. Now, the woman on the right, there is two pictures of her. The one on the right is before she developed hyperthyroidism, and the one on the left is after she developed hyperthyroidism. There's literally like a bugging of their eyes. And if you look at individuals from the side, there is significant bulging of their eyes. And this is one of the hallmarks of hyperthyroidism. Next slide. The fetal effects or preterm delivery may or may not be indicated. It may be spontaneous, low birth weight, miscarriages, and stillbirth. Next slide. So to diagnose hyperthyroidism, the TSH is decreased and the free T4 is increased. Now, in order to treat hyperthyroidism, you can use propylthiouracil, PTU, or you can use methimazole, or what we call tapazole. So tapazole should be avoided in the first trimester because there's an increased risk of cutaneous aplasia, and that is an area on the scalp that will not grow hair, and there is a risk of cloacal atresia. Now, the incidence of a birth defect on individuals who are taking tapazole is about 2 times greater than the general population, and that's based on a conglomerate of studies placed in a meta-analysis. The other issue is that the FDA actually gave a black box warning for propylthiouracil. It was probably 3 or 4 years ago that said this medicine should not be used because there has been, 13 cases of fatal hepatitis. The issue is PTU has been used for decades. And yes, nearly every drug can give you hepatitis. But the amount of hepatitis from PTU is really low. And both drugs, PTU and tapazole, can cause agranular cytosis, meaning like their blood count goes to 0, and you can literally die from an overwhelming sepsis. And it's a little bit more common with methimazole than PTU. Now, it depends on who you read as to whether or not you change a patient who is on PTU to methimazole after the first trimester, or do you keep them on PTU? So I personally, if they're on PTU and they've been well controlled, I personally think we should leave them on PTU. And ACOG gives us the permission to do so. They say both drugs have a side effect and we should do it with shared decision making with the patient. And that I agree with. Now, if somebody is on methimazole and they get pregnant, I do change them to PTU to get them out of the first trimester. Now, it takes 2 weeks or so for patients to decrease their symptoms of thyroid disease. And therefore, if patients are having palpitations and a rapid heart rate, you can use propranolol to decrease that heart rate. And that's the preferred beta blocker for it. Next slide. Now, hypothyroidism again is has a lot of the same overlap symptoms as pregnancy: fatigue, constipation, weight gain, edema, dry skin. And one of the unique characteristics is a prolonged relaxation phase of the deep tendon reflex. I promise you, I have never seen that. Okay, that's what we read in the textbooks, but I have never seen that. I don't even know if I would recognize it if I did see it. Next slide. So, hypothyroidism, the problems with the fetus is that there can be a low birth weight and there can be impaired neuropsychological development. Next slide. And the way we diagnose hypothyroidism is they have an elevated TSH and a free T4 that is below normal. Now, the way we replace these individuals is with Synthroid, and you have to be careful when you're first starting it to start it at a lower dose and go up, because if somebody has a very low thyroid and you start 75 micrograms, you can actually cause them to get an arrhythmia just from feeling or a hyperthyroid relative. Okay. And Synthroid is the one drug that I would consider using only the name brand. There are some states like North Carolina, you cannot get generic Synthroid. And so why do I say that? Well, the drugs that we get, generic drugs, they come from all over the place. China, India, and the quality controls on those drugs are not as good as the brand name Synthroid, and therefore the amount you get is exactly right in the name brand, and it may be a little bit different if you get generics. Now, for sure, if I have somebody who is having problems with their thyroid, it's going up and down, then I for sure make that individual get only the name brand. Next slide. So this is a very complicated slide. It actually comes directly from the ACOG practice bulletin. And, you know, if you suspect thyroid disease, you can check your TSH. If it's elevated, then you check your free T4. And if it's normal, no further evaluation is needed because the diagnosis is subclinical hypothyroidism. But if the TSH is below normal range, then they have overt hypothyroidism, and you should replace them and recheck their TSH in about 4 weeks. If you check a TSH and it's normal, then the patient is euthyroid and you don't need to do anything else. If you check a TSH and it's decreased, then check your free T4, and it says and total T3, but I just check the free T4. If it's normal, they have subclinical hyperthyroidism, but if it is overtly elevated, then above normal range, then they have hyperthyroidism. Once you make the diagnosis of hyperthyroidism, you can check the thyroid stimulating immunoglobulin and the thyroid receptor antibody. We call them TSI and TRAB. And those, the people who have really high levels of those are at increased risk for fetal hyperthyroidism because both of them can cross the placenta and stimulate the fetus to produce more hormones. And the only way you can detect this is by cortocentesis, or if the baby has a sustained tachycardia. Now, the other antibody that we hear a lot about is TPO, thyroid peroxidase. And TPO is associated with Hashimoto's. It does not cause hypothyroidism in the fetus, and you don't need to check it. Next slide. So, thyroid screening in pregnancy. Please get the message out. Universal screening is not recommended. There was a large MFMU network study that looked at subclinical hypothyroidism and followed those children up. And subclinical hypothyroidism should not be treated, and it does not alter the IQ of the baby. So please, I'm seeing it more and more. There's universal screening in pregnancy, and that is not recommended. At-risk individuals are your type 1 diabetics. 40% of them develop thyroid disease, because thyroid disease is actually an autoimmune disorder usually. And so if you got one, you're at increased risk for a second one. Now, you have a family or personal history of thyroid disease, like if you had Graves and your thyroid was errated, ultimately you're going to get hypothyroidism. So what I would recommend is you check in a TSH on those individuals. People with advancing maternal age are also at increased risk for thyroid disease. Approximately 40% of women will ultimately develop thyroid disease. And if you are in a country or an area with low iodine intake. Now, I am going to give you an example, or we're going to do a case of a hyperemesis, and I'm going to tell you not to screen for it, and we'll talk about it, why you don't. Next paragraph, or next slide. So a thyroid is storm, can be deadly. And the patient shows up with fever, tachycardia, cardiac dysrhythmias, and central nervous system dysfunction. Thyroid storms are rare, but if you see one, you will not forget it. Now, you also can get heart failure from thyroid disease, hyperthyroidism. The T4 can be toxic to the cardiac muscle and cause a cardiomyopathy. We actually had a maternal death in a patient due to heart failure because she would not take her medicine. She would come in a thyroid storm. She would have an ejection fraction of 50%. And so we were going to do a thyroidectomy on her during pregnancy because she was so non-compliant. And the day that she was scheduled for her surgery, she died of congestive heart failure. Next slide. I think that's my last one. Okay, so I'm going